You need to know this on your boards. Do you have Lyme disease?
I don't think so.
In Oregon?
I think more east coast.
Like Connecticut and things, yeah. Okay. Here, cocci is huge. That's the reason why we send cocci serologies. If you guys end up training in a hospital here, cocci is very common, very, very common. You're going to see it throughout your training here. Meningococcal, again, you think about young adults living in crowded living conditions. And if the patient has recurrent meningitis, you think about herpes. There's a variant of HSV, it's called the Molleret's meningitis, recurrent. My wife's cousin has it, and she needs to take acyclovir for the rest of her life. Otherwise, she's gotten like 7 episodes in her life. And then you think about weird complement deficiencies, or patients that are actually like they don't have a spleen anymore. You think about like infections with encapsulated organisms, including Neisseria meningitis. Okay, so this is basically the empiric therapy. This is, you don't need to know this for your boards. You just have to know what you're suspecting, but I left it there for your review. So if you have if you have a positive grind stain, you need to narrow it down to either meningococcus, pneumococcus, or listeria. And for those patients, you give a 3rd generation cephalosporin, you give vancomycin, and you give ampicillin. So that's when until you get a definitive culprit. That's the reason why we always start big and then we start narrowing down. By day 2, most cultures are back. If you suspect meningococcus, then you need to send the patient for droplet isolation. One time I was admitting in the hospital, and one patient got admitted with meningococcal meningitis, and I ended up everybody that was there, we ended up getting treated. They gave us like rifampin for a few days just to cover the basics. But these patients typically on your boards, they show somebody who's very sick, like the petechia and the very septic. But usually if you're in a classroom or like a random contact, you're not supposed to be there, but the guy was coughing all over, so that's the reason why we ended up all getting treated with rifampin. Okay, so this is, if you have a lot of lymphocytes, you think about aseptic meningitis, but you also think about TB. And you guys know how do you diagnose TB in the CSF? So you either do an AFP, you do an AFP and an AFP culture. It takes about 3 to 4 weeks. If you suspect it, you treat it. You don't wait for 4 weeks, because these patients get very sick and they die. The Rocky Mountain spotted fever, they typically give you a history of like hiking in the typical geographical area in the United States, and the treatment is doxycycline. Lyme's disease, again, you suspect Lyme's disease when they give you a classic history, the rash, the exposure, whatever, and these patients may present with a focal neurological exam. You treat them with IV ceftriaxone or cefotaxime. If you're thinking about enterovirus, there's really nothing that you do, it's just supportive. Some drugs are associated with aseptic meningitis, including NSAIDs and IVIG and Bactrim. You don't do anything, you just offer supportive treatment and you stop the offending agent. And if you're dealing with Cryptococcus, definitely you need to treat them right away with amphotericin. My last transplant patient that was diagnosed with cryptococcal meningitis, we had to stop all the immunosuppression, and basically the kidney ended up rejecting. The kidney ended up like basically dying. But it's either that or the patient's life. If you keep these patients immunosuppressed, you can give them rounds and rounds and rounds of fluconazole. They're not going to get cured unless you stop the immunosuppression. Okay, so encephalitis, I already told you guys, if the patient is very confused, you think about encephalitis. Here in LA, we have West Nile. I don't know if you've ever seen somebody with West Nile. It's a nasty disease. It's very sad, because sometimes the patients, there's nothing that you do for them and they end up dying, or they end up developing permanent brain damage. Fortunately, those are the exception and not the rule. The rule is more like a self-limited disease. You get like influenza-like symptoms and it just goes away. But for those patients, they end up in the ICU with no clear explanation of what's going on. We send the CSF analysis to the state laboratory, and they run like all sorts of like viral meningitis, including like there is like a equine meningitis, there is Venezuelan equine. I mean, I saw the result from one of my patients. The panel is this long, and West Nile is one of them. And again, West Nile is bad news. If you develop encephalitis on this, you're more likely to end up with permanent damage. And there's no treatment for this. So rabies, I've never seen rabies. I don't know if you guys have seen rabies, but I think it's on all over the news when we have that. Mumps, this is one of the complications in encephalitis. Varicella is one of the complications. Very good. And this is a high yield point for your boards. If you have if they show you a CT or an MRI, and if you see temporal lobe changes, you have to treat the patients for presumed HSV encephalitis because it changes mortality. So typically you have like the classic, I don't have a slide here with the picture, but typically you look at the temporal lobes and you're going to see diffuse inflammation. You have to cover those patients with acyclovir. Okay, so HSV, we know that the type 1 HSV is usually the non-genital, and the type 2 is predominantly the genital. But the common infection in the general population is usually type 1, it's about 80%. And it's a very common infection. Actually, millions of people in the United States have been tested positive for this. Like I remember like reading somewhere like 40 or 50 million people in the United States actually is positive for type 1. But the key point for you guys, if you end up in a clinical setting or in a hospital setting, is that when you suspect aseptic meningitis or aseptic encephalitis, you need to treat the patients right away with acyclovir, and it really changes the natural course of this disease. Okay, so these are other syndromes associated with HSV: dendritic keratitis, encephalitis, unilateral temporal lobe lesions, and aseptic meningitis. Again, the treatment is the same. It's just like different manifestations from the same disease. Okay, varicella zoster. When I was a second-year medical student, I started having fevers and horrible back pain, and I went to my doctor. I remember like yesterday. I went to my doctor. I've never heard about shingles. I knew nothing about that. So I went in, and the guy told me, "Oh, you have shingles." And like, what is that? So it was very stressful. It was very stressful. I was taking finals. I was just like you guys, taking finals, and I had an outbreak. And to this date, I still remember how painful it was. So I want to give you some pearls about shingles, because you're going to see this a lot, but you need to suspect it. You know, I'm going to give you clinical scenarios where I've seen shingles. One day they called me, the emergency medicine doctor called me to admit a patient with chest pain. Every time you have a patient with chest pain, I want you to examine the chest wall, always. The patient didn't really have chest pain, but the patient was a really bad shingles outbreak, and they already started like the pathway of checking troponins and doing all that stuff. It was not chest pain. So always examine the patient's skin. If you don't see the rash, it doesn't mean that it's not shingles, because the pain usually precedes the onset of the rash by 2 to 3 days. So tell the patient, you know, I don't see anything, but the pain that you're describing is out of proportion from the findings. You know, I'm not seeing anything. And if you develop a rash, you need to come back. Or if the patient has had shingles and they're telling you, you know what, this feels like shingles, nobody will fault you from treating that patient as if they had shingles. The treatment is not curative. We know that once you get herpes, it's for the rest of your life. But what the treatment does is actually shortens the duration and the severity of the symptoms. And you guys know that when you develop a serious case of shingles like this gentleman involving the trigeminal nerve, one of the complications is actually you can get a keratitis, like the cornea involvement, and you can actually go blind from this infection. So that's why it's important that you suspect it and you treat it aggressively. Another thing is important that you guys know is that we have a vaccine available. It's called Zostavax. It's a live attenuated vaccine. You cannot use that type of vaccine for somebody with immunosuppression or with a transplant, because you can actually develop shingles from it. but the FDA approved it for anybody with or without history of shingles. Before, it used to be like only if you didn't have shingles. Now the recommendation reads you give it to everybody after the age of 60 with any comorbidity. Like if you have hypertension, diabetes, you recommend it. Some insurance plans don't cover it, and it's about $300, but during the pain that I had, I think it's totally worth it. I mean, I would totally, I mean, I'm not 60, but I'm gonna get it right away when I'm 60. Okay, so in the management of the post-herpetic neuralgia, you guys know how to manage that?
Like neuropathy meds?
Yes, very good. Which one? Gabapentin works pretty well. Yeah. How do you prescribe gabapentin, by the way? So you have to start very slowly. You never give, let's say, gabapentin comes in 100 and 300 milligrams. You never give like 300 up front because patients will have a lot of like sedation and dizziness. If they have advanced renal disease, you cannot use it. If they have intact renal function, you can probably just tell them like, I want you to take 100 milligrams 3 times a day. If it doesn't do it, I want you to do 200 3 times a day, 300. And the maximum dose is like 2,400 milligrams per day. You can break it in 3 to 4 every 6 hours. You can break it, but you don't prescribe high dose upfront because the patients are going to have like a lot of side effects. It's very effective. Like some studies, some physicians prescribe steroids. The data on steroids, you know, is not very good. There's really no effective topical treatment. All your patients are going to ask you for something to apply because the pain is so bad. Just tell them just leave it alone. Just leave it alone. That's all you need to tell them. Just take the acyclovir, or you can actually do the Valsite. It's more expensive, but if money is not an issue, you can do Valsite, which is more convenient because it's twice a day instead of like 4 times a day. And the typical acyclovir dose is about like, it's anywhere from 400 to 800 milligrams 4 times a day. It's a pretty high dose for 5 days. Okay, so varicella, you guys know that herpes zoster, yeah, reduce the incidence, yeah. So basically, my grandma developed it, and she always had the pain ever since. For the last 5 years of her life, she was in pain in her back. So it's a disease that is not serious, but it carries a lot of morbidity, and it really affects the quality of life, especially from the elderly. That's why you want to treat it aggressively. Okay, influenza. Do you guys all have a flu shot? Who didn't? You didn't last year?
Oh, last year. Not for this.
Okay, not this year. No, this year is just coming out. But did you guys all get the flu shot last year?
Yeah.
Okay, flu is a serious disease. You guys were probably not even in med school when we had the H1N1 epidemic in 2009. I have never seen anything like that in my life. I saw healthy people like you guys dying on a ventilator, in the oscillator ventilator. We couldn't ventilate them from massive like ARDS and basically people dropping dead like left and right. Influenza has the same mortality in the United States. Listen to the statistic. Influenza has the same mortality as breast cancer. Just to tell you how crazy it is. So it kills a lot of people, especially the elderly. But it's very sad to see people like young, healthy people die, especially pregnant ladies die during that outbreak. This year, they call me, these patients with H1N1, they go down, they develop multi-organ failure, and they develop ATN. And they've done biopsies, and they've done like molecular analysis, and actually the virus also involves the kidneys. So they call me to dialyze someone who was pretty much brain dead. He was completely brain dead. So the story from this guy is that him and his wife, they went to Texas, they flew back, the lady got vaccinated, she got hospitalized with pretty severe pneumonia, but she made it out of the hospital. The husband never came out. He never really had a vaccine. So what research shows is that vaccination not only, well, protects you from getting it, but if you end up getting it, you get a lighter or milder form of the disease. This poor guy, basically, there's nothing we could do. Finally, we were able to convince the family that dialyzing him was not going to do any good. I mean, the guy was completely brain dead with no brain activity like for 2 weeks until they agreed to just disconnect him from life support. But influenza is a nasty disease. Your job as a student, if you're a good resident, good intern, you have to educate your patients. And you have to you don't have to scold them. You have to try to understand the reasons, the misconceptions why they don't want to get vaccinated. Once they hear it from you, once you offer them the evidence why this is so important, you know, I cannot tell you how many patients in my practice they've gone from stage 3 or 4 kidney disease stable from becoming dialysis dependent after getting an influenza pneumonia. It's silly. Like, we have something that can really protect you, keep you away from the hospital. So your job as a student is to tell him this is a serious disease. Everybody needs to get vaccinated. We all know the symptoms. If you have the flu, you know, you don't come to work because you're going to spread it to everybody. For you guys, if you're in the front line, if you work in the urgent care, treat everybody during those months. Treat everybody that comes in with influenza-like symptoms, like myalgia, sore throat, runny nose, high fever, chills. I treat every patient universally. Why? Because Tamiflu is very safe. It's not a toxic medication. It doesn't really have a lot of interactions. And if you're really dealing with influenza, you know, you're gonna protect your patients. There is a rapid influenza test. I never prescribe it because about up to 10% of false negatives. And if a patient comes in with the symptoms, I'm just gonna go ahead and treat them. So that's one of the teaching points.
Do you still treat even beyond the 72-hour mark?
I sometimes do. For those patients that are very sick or multiple comorbidities, I still sometimes do. But I know that the recommendation says up to 48, 72 hours. Mm-hmm. But you know, you're never going to be faulted by giving Tamiflu treatment. Okay. So otitis externa, you guys, if you see these swimmers here, you think about Pseudomonas, you think about diabetes. This is quite common in the urgent care setting. Sometimes the patients have like the malignant form and they get like intracranial complications, including meningitis or brain abscess. The one that you're going to see mostly in the urgent care is like the typical swimmer's ear. You know, typically, how do you treat the swimmer's ear? You guys remember? So if it's just a classic swimmer's ear, you just treat it with topical treatment. Topical treatment is ciprofloxacin, like they have like either ophthalmic or otic drops. You can either use one or the other. You put like 2 drops in each ear. 2 drops twice a day for a total of 7 days. That's how you treat it. But if the patient has systemic symptoms, or you know, they already have like chondritis and like on exam you can't even touch them because they're so sensitive. Like when you have like an acute inflammation of the cartilage, when you're doing your exam, they're not going to let you do an exam. They're so tender. For those patients, I definitely do treat them with anti-pseudomonal fluoroquinolone, like Levaquin, for a total of 4 weeks. That's what I normally do. Yeah, they may need surgical. I always refer, when they're that sick, I always refer to ENT, because in the urgent care, you're not going to have the tools. You're not qualified, and you're not going to have the tools to be able to tell whether or not this is involving the bone. Okay, so cats and dogs. Who loves cats and dogs? Actually, I have 4 dogs myself. So I've always had dogs. I love dogs to death, and I've never had an infection like this. When I was an intern at Oliveview, I actually a cirrhotic patient got admitted, and he grew Pasteurella in his blood. I've never seen anything like that. That was the first and the last time I saw it. So on further questioning, my attending at the time told me, like, this guy must have a dog. I didn't know why he was saying that. So we went back to the ward and we asked the guy, hey, do you have a dog? And the guy's like, yeah, I do have a dog. Does the dog lick you? Like, and he stayed like silent for 1 second, like, yeah, he licks me. Where? And then he pulled his legs. He was cirrhotic, he had a lot of edema, he had some like superficial ulcerations. The dog was licking him on his ulcerations, and the guy became so sick, he developed a Pasteurella bacteremia. So very common in both dogs and cats, a little more in cats. It's a bacteria that can be very invasive. That's the reason why when you get a cat bite, you always treat with augmentin. Cats have a particular thing compared to dogs, is that the teeth are more sharp, and the wounds can be deeper. So the inoculation of the bacteria can happen in the deeper soft tissues. So you got to be very cautious about like these patients when they present like with a history of cat or dog bite, and I usually give them antibiotic prophylaxis for 3 to 5 days, and usually I use augmentin. Okay. Human bites. So you guys like soccer? What's his name? Come on. He's from Uruguay. What's his name? You guys need to love soccer. That's why we need more people loving soccer so we can beat Uruguay one day. His name is Luis Suarez. This guy has a tendency to bite. He's been I don't know how many rivals, but anyway. So human bites on your boards. If they give you a human bite involving a joint, like let's say that you have a fist fight and one of the guy like punched in the teeth and the injury goes into the joint, those patients, they need admission. They need IV antibiotic and they need a joint washout because they can actually develop like serious infection. But generally speaking, if you get a bad fight, I usually treat them with antibiotics just for medical legal reasons. Because all of these patients showing up in the urgent care after being attacked, they're usually pursuing like legal action. So you may want to make sure your documentation is very clear. All right, MRSA infections. I think I told you guys there's a community-acquired MRSA, and there's a hospital-acquired MRSA. Usually the hospital-acquired is a lot more resistant. They've done epidemiology studies, and like recently I saw that they isolated MRSA in the Santa Monica Ocean, in the beach. So not everybody develops the syndrome, the disease, but for some reason, some patients are very susceptible to get recurrent boils and recurrent soft tissue infections. The management, typically, if you're in the urgent care, I usually prescribe clindamycin. I know that there is some significant resistance. Some doctors, what they do is they prescribe Bactrim. That's another choice. But Bactrim can sometimes be a very tough medication to tolerate. If you have kidney disease, you can't use it. And I usually try to stay away from doxycycline. I stay away from fluoroquinolones. And linezolid is only IV. So, you know, typically, if you're in the ER, urgent care, and you suspect MRSA, remember, you suspect MRSA when the patients have risk factors, or when they actually, like men having sex with men, or when they're like weightlifters, or they spend a lot of time in the gym, and they have like abscess formation, they have boils. So if you just see plain cellulitis, that's almost never MRSA. That's an important point. MRSA very, very commonly develops boils or abscesses, like soft tissue abscesses. So when you suspect that, and every time you do an IND, I usually send it for culture, because if they do have MRSA, you need to call the patients for more antibiotics typically. So these are like the IV drugs that we use. Vancomycin is a very good medication. It's a large molecule. You can get red man syndrome. That's not an allergy, that's just an infusion dependent reaction. The way you fix that problem is by increasing the infusion time. Instead of doing it in 1 hour, you just do it in 2 hours. And I don't usually write allergy to vancomycin when they develop red man syndrome, because it's an expected side effect when you're running the infusion too fast. But these are the other anti-MRSA options. So neck fash, you cannot miss this neither on your boards nor in clinical practice. If you discharge a patient home with neck fash, this is a huge malpractice. This is a huge liability. And the reason, sorry guys. Kai, I sent you a text. This is from your buddy. Ramiro. From your right kidney, Ramiro. Yeah. 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 So basically, who do you suspect necrotizing fasciitis? Let's say a patient comes into the urgent care. And the patients start describing like severe pain out of proportion to the physical exam findings. This is like one of the first manifestations. If they're a little more advanced in the clinical picture, the patients may look septic appearing, But the interesting thing is that it's a deep tissue infection. So when you look at the patient's exam, you don't really see anything. If anything, you may see a little discoloration, maybe like a little black, like early phase lesion. The problem is that this condition progressed to actually very serious life-threatening infections. Have you guys heard about Fournier's gangrene? Okay, so this is a form of necrotizing fasciitis. It just happens in the perineal area in males particularly, and it's very sad because once you develop like the whole syndrome, these patients require like extensive debridement to the point that sometimes they just need to do amputations to save the patient's life. So the empiric antibiotics, you always do vanc and you add clindamycin, and you either in a beta-lactam. These patients, you need to treat them aggressively because typically this is polymicrobial. It's anaerobic, strep, enterobacter, and some patients, what we call type 2 necrotizing fasciitis, is usually associated with group A strep. But don't ever forget necrotizing fasciitis. That's going to be on your boards, and you're going to see that in real life. Gas gangrene. So when you order an X-ray, let's say that you have a patient with a foot infection or something, you look for two things when you're actually looking at an X-ray. You're looking for osteo. You're looking for any acute findings, obviously fracture, dislocation, things like that. But you're looking for osteo findings, like erosion of the cortical bone. But you're also looking for gas. So every time you look at an X-ray, somebody presenting with like I step on a nail or something infectious, you look for gangrene. This entity, the patients actually, they require immediate surgical debridement, penicillin and clindamycin. And if you see gas on an X-ray, that's pretty ominous. Actually, if you send the patient home with a gas in an X-ray, that they're going to come back a lot more sicker than when they first came in. They're going to have a lot of systemic toxicity. You know, the bacteria, it's a Clostridium. What's the last name of that Clostridium? Clostridium what? Perfringens. Thank you. Clostridium perfringens. Very good. So the streptococcal toxic shock syndrome. Usually the patients, they give you a history of a group A strep, usually like a skin and soft tissue infection. The patient's presenting with fever, hypotension. And remember, it's not mediated by the bacteria itself, it's just mediated by toxins that they cause massive release of inflammatory cytokines and capillary leaks and tissue damage. These patients, you need to treat with IV fluids, immediate penicillin and clindamycin, because clindamycin binds to the toxin, and that's the right answer for your boards, both penicillin and clindamycin. And typically it's associated with a prior exposure, like a soft tissue, the skin or soft tissue infection. The other one that you're going to get on your boards is the toxic shock syndrome. Typically, these patients they're very sick, they present with multi-organ failure, and usually it's associated with toxin producing Staph aureus. Without any invasive disease, they may give you like either a patient that had like some sort of like wound that was packed, or a lady that was using a tampon. So this actually disease, I've only seen it once. The patient was very, very sick, she made it out, and she developed it from an IUD, believe it or not. You know, my attending was actually impressed, like never saw it with an IUD. Okay, so Vibrio, typical exposure, like the patients were actually like doing some like diving in the reef, salt water of the Gulf of Mexico. Usually they're gonna give you a history of trauma, and these patients they become very sick very quickly. The risk factors for developing this infection is cirrhosis. If you remember, that's the reason why cirrhotic patients should not eat raw shellfish or any seafood, because they can actually develop a fulminant form of Vibrio. So on your boards, they may give you a guy with cirrhosis, like eating some uncooked shellfish, and this is what happens. Infectious arthritis, this is one of the things that you need to protect yourself when you work in urgent care. If a patient presents with synovitis, you need to stick a needle in that joint. If you let the patient go without the diagnosis, if they have an infectious arthritis, that's going to cause permanent disability, or they can even get very, very sick. So typically you need to do an arthrocentesis. If you don't know how to do it, you call, most hospitals, they have an ortho PA. That person is very knowledgeable. They just go in and they access the joint. That's what I do. I get a patient. I need a arthrocentesis. If it's the knee, I do it myself. It's very easy. If it's some other joint, I call the ortho PA, and he always does it for me. Yeah. So, but make sure you don't miss this. Okay. Arthritis for gonorrhea. Typical feature is there's a migratory polyarthritis, and they may give you also, what is the name of that syndrome where gonorrhea is disseminated to the liver? Yeah, they may give you, that's the other scenario that you may encounter on your boards. Typically you treat with ceftriaxone including doxy, because you always want to treat everybody with gonorrhea. You always want to treat for presumed chlamydia as well. Okay, osteo, again, like I said, you look for erosion, like non-healing ulcers. It can be either contagious spread or hematogenous spread, and patients usually are, they have predisposing conditions like peripheral artery disease, diabetes, or skin ulceration with local infection. Some patients actually may present with chronic osteo, and they don't necessarily look toxic, but they have it like for months or years. But when they present with acute osteomyelitis, it's very painful. The patients, they cannot even walk, and they can present with acute infection symptoms. Staph aureus is common, but you also get a lot of like organisms, like including gram-negative rods in the diabetics, like a diabetic foot ulcer. So the diagnosis is like an X-ray. You check an ESR-CRP. They're usually very elevated. ESR-CRP is useful. The higher they are, the more likely that you're dealing with a bone infection. So it's almost impossible to have osteo with a normal ESR. So if you have an ESR of 80, 100, then you know you're probably just dealing with the real deal. You can either do a nuclear medicine scan or an MRI if the X-ray is negative. But the bottom line is that the gold standard is to do like a sterile metal probe to the bone to be able to connect, to be able to collect the culture. That's usually done by the podiatrist. We don't do that. The treatment, usually you think about, if you suspect MSSA, you treat with oxycillin. MRSA, you treat with Vanco. And if you think about like diabetes and gram-negative rods, you just give them an oral fluoroquinolone. All right, STDs. You're probably very savvy about STDs. I'm going to cruise really quickly through these slides. So, treatment of gonorrhea. You know treatment of gonorrhea? How much? 250. How many times?
5.
Times 1. Times 1.
Oh,
Yeah.
okay.
You don't let them go. You say, "Come here. I'm going to give you a shot." And what else do you treat for? Chlamydia, always. And what do you treat chlamydia with?
Azithromycin.
Doxy, yeah. Oh, yeah, azithromycin, doxy, yeah. Yeah. So, and you always treat the partner. So, you're not gonna get faulted. It's up to you. I usually give them prescriptions so they can give it to the partners, even if I didn't see them, because I'm more like laid back. Some doctors, they like, oh no, they need to go and see the doctor. But I feel like by giving them right there on the spot, they're more likely to end up taking it. Fluoroquinolones are not recommended anymore because there's a high risk for resistance. This is the typical disseminated gonococcal infection. This is serious, and these patients, they require like inpatient management. It's not just 250 and go home. No, they can become very, very sick very quickly. Okay, these are actually real slides from the days that the U.S. was very aggressive about like eradicating sexually transmitted infections. Chlamydia, things to know is that you treat it either with azithromycin times 1 gram times 1, or you give doxy 100 milligrams BID. If they're pregnant, you either treat it with amoxicillin or azithromycin, and you need to treat all partners. PID. So PID is actually a tricky thing because PID is a clinical diagnosis. It's not just necessarily some sort of magic test that's going to tell you the treatment. For you to be able to diagnose it, you need to do a pelvic exam. And the classic symptom is the cervical motion tenderness. These patients, the higher risk is usually obviously young sexually active females. But it's kind of tricky because once you diagnose it, there is always the possibility that it can be not necessarily related to chlamydia or some other like gonorrhea or some other sexually transmitted infection, but it may be a polymicrobial. So it becomes a little tricky because usually when you disclose the diagnosis, they get all like, oh my God, how did I get it? And like my husband, he's cheating on me. So for that reason, I almost always do cultures. You know, you do a gram stain, you do a wet man, and you send samples for chlamydia and gonorrhea, and you just tell them like follow up in clinic. So you guys can discuss the results. But it's a clinical diagnosis. When you suspect it, you treat it, and if the patients are clinically stable and non-toxic appearing, you just do outpatient treatment with oral doxycycline and ceftriaxone. I usually treat them with 14 days of doxycycline when I make the clinical diagnosis. Trichomonas, look for the strawberry cervix if they tell you that. They usually the discharge is usually very malodorous, and you diagnose it with a wet mount. Most urgent cares will be able to give you the wet mount result within an hour. So if you want to wait, I usually send them out, but I follow them in the clinic. But the way you treat it is with 2 grams of metronidazole times 1, and again, you also need to treat all partners because this is a protozoan sexually transmitted infection. Okay, so genital ulcers. If you remember this, syphilis, it's painless. Herpes is very painful. Chancroid is painful, and they have lymph nodes. And LVG, they don't have any pain, but they actually have very tender nodes. I've never seen LVG in the U.S. So this is before penicillin, World War I. Everybody had syphilis. It was impressive. All right. So why don't you help me read this question?
26-year-old sexually active male comes to the STD clinic for routine screening. He has no complaints and physical exam is normal. Review of the chart shows that he had a non-reactive RPR at his last visit 8 months ago. A repeat RPR today is reactive at 1 to 1024. What is your diagnosis?
What do you think?
8 months, so it's going to be like early latent. Is it late latent at beyond 12 months?
Yeah, early latent, I would say.
Okay.
Yeah. So it's less than a year, right?
Mm-hmm.
Okay. And can you help me read the second one? Thank you.
What is the treatment of choice for this patient? A. Benzathine, penicillin, G 2.4 million units IM in a single dose. B. Benzathine, penicillin G 2.4 million units IM in 50 consecutive doses once a week for 3 weeks. C. Aqueous, crystalline, penicillin G 4 million units IVQ 4 hours for 14 days. Or D. Doxycycline 100 milligrams PLVD times 14 days.
A. B is for tertiary, C is for neurosyphilis, and D, it doesn't apply to syphilis. All right, so we all know the primary syphilis is the easier one, 3 to 6 weeks. Secondary syphilis, the great mimicker. These patients can have like all sorts of like systemic symptoms, anorexia, weight loss, arthralgias, and usually like 2 to 8 weeks. And latent syphilis, we talk about latent syphilis when the patients actually have like more than 1 year or the duration is unknown. Tertiary, you guys don't get to see any of that stuff, but when I was in med school, actually I saw a lot of this, like tabes dorsalis. Patients were like severely incapacitated, and like these bizarre like aortic aneurysms. You have like these gumas, like these balls in the skin, and patients will have like meningovascular disease. Fortunately, we don't see that anymore. Once in a while, like I encounter like, since I became a nephrologist, I've diagnosed like 3 tertiary syphilis because part of the workup of renal disease is to check for syphilis. And these patients, they ended up getting treated with the protocol that I just mentioned. Primary syphilis, we all know, very familiar with this lesion. Secondary syphilis. All right, so we know that the screening test is the RPR and the VDRL, but the confirmatory test is the treponema test. Remember the TTPA and the FTA-ABS. The serologies will remain positive. There's two things that will go with you: your step 1 score and your syphilis serology for the rest of your life. So don't forget that. If you already took step 1, I hope you did well. So, okay, very good. So treatment, we already covered. Neurosyphilis is actually inpatient, like 10 to 14 days with penicillin G. If you're pregnant, if you have a penicillin allergy, the answer is still treated with penicillin. There's some desensitization protocols that needs to be done by an allergist. If the patient has neurosyphilis, the answer is the same. There's no other antibiotic that is superior to penicillin to treat tertiary or neurosyphilis. So these patients they need to be desensitized. Okay, genital herpes is very common, like very, very common. So it's basically very painful. Like the first time can be more painful than ever, and the first time patients can actually have like systemic symptoms, fever, myalgia, inguinal enopathy, and the recurrent episodes may have like a little prodromal period. The diagnosis is usually by a viral culture or PCR, which is more sensitive, but serologic studies are useful for counseling couples. I had a woman recently. She was very stressed out and she really wanted to know. Clinically she had it, and again, for those patients, you're not going to say no, we're not going to do the testing. You just tell them, let's do the testing, because you want to be reassured. Very painful. Okay. So treatment, we know it's like either Valsite or acyclovir. What are the side effects from acyclovir, by the way? You guys know what happens if you give acyclovir? What do you tell the patient if you prescribe acyclovir? You're going to tell your patient drink a lot of water, because they can actually precipitate and they can form crystals and they can be associated with acute kidney injury. So drink a lot of water. Okay. So recurrent episodes, you treat with the same meds and lower doses, obviously. Oops. Yeah. And daily suppressive therapy is associated with like decreasing the frequency of the episodes, decreased frequency of the episodes, or decreased transmission to the sexual partner. I'm sorry, it's like I'm on call. Okay, so chancroid, it's common in developing nations. I've never seen it in the US. The physiopath is the organism is the H. ducreyi, Haemophilus ducreyi. They're painful genital ulcers, and they give you like these lymph nodes that they ooze. It's a diagnosis after you rule out like the other more common syphilis and HSV. And these patients, it's easy to treat. It's just like I've never seen it. It's very painful ulceration. So if you see painful ulceration, you think about herpes and you think about chancroid. Okay. LVG, Chlamydia trachomatis is the organism associated with it. The patients have painless ulcerations, but they have tender lymph nodes. You treat them with doxycycline, and this is like an example of the lymph nodes. They get pretty hard and indurated and painful. I saw one case when I was in practice over there. Okay, genital warts, usually perianal are common in men having sex with men and associated with squamous cell carcinoma. They're usually asymptomatic, but it's a clinical diagnosis. And right now we have an HPV vaccine that's recommended for, initially was the females, now it's males and females alike. And typically we know the serotypes that are associated is the 6 and 11, but on your boards, the ones that are associated with risk for cancer are the 16 and the 18. Okay, these are Antifungal questions, I'm going to leave it for your review, because this is, just want to be able to cover, because we have a lot of slides yet. Let me see. Yeah, we still have a lot of slides. Okay, so invasive fungal infection on your boards. Okay, here in California, we don't have blastomyces, we don't have histoplasma. We have cocci. This one I've never seen here. I don't even know what that is. And the Esporotrix is usually the rose gardener, you know, the alcoholic guy who's fixing roses, and they develop like this lymphangitis. I'll have a picture I'll show you later. And then the opportunistic yeast infection in molds. So we have Candida. It's common in immunosuppressed patients. Candida is very common in diabetics, and also the Candida vulvovaginitis is quite common, but that's not a sexually transmitted disease. It's just very common. Cryptococcus, we spoke about Cryptococcus, is a serious disease. It doesn't happen in an immunocompetent host. Aspergillus is also a classic aspergilloma on the chest X-ray, or like a aspergillus ball. This also happens in immunocompromised recipients. Pneumocystis carinii is a very, very aggressive infection. Patients actually, they can go from being room air to be mechanically ventilated within hours when they're actually develop a pneumocystis pneumonia. On your boards, they're going to give you a scenario of somebody with HIV or immunosuppression, and they're going to give you a high AA gradient. They're going to give you like I think the arterial saturation usually is lower, like arterial oxygen saturation is lower, and they're going to give you a high LDH, and basically they're talking about pneumocystis. And the zygomycetes, I've never seen it. So this is classic sporotrichosis. The rose garden disease is associated with all those occupations, and typically alcoholics. Treatment is usually itraconazole for about 4 weeks until the lesions are resolved. Patients can get very sick if you don't treat them, by the way. Okay, candidemia. If you have a patient with blood candida, that's very serious. You need to treat them very aggressively, and that's an absolute indication to remove the line, no matter what the line is. If it's a dialysis catheter, if it's a TPN line, whatever the line is, that line needs to come out. Otherwise, he's never going to clear that fungemia. You need to, every time you have that, you need to do a dilated ophthalmology exam, because the disease actually it's common to involve the endophthalmos, the retina. Okay, if you've never seen mucormycosis, I'm going to tell you 2 things about this disease. Very rare that if you survive, if you develop this disease, it's rare if you survive it. It's actually a very ominous thing to have. Mucor is actually a very common, you know when you guys leave the bread outside for a long time? That's mucor. That's actually, nobody gets it, like an immunocompetent host doesn't get it.